Okay, welcome everybody. I'm Kim Agard. I'm the Chief Financial Officer at Astera Health. We're going to talk today, sorry, I don't know if you guys can see that little box on my screen, maybe not. We're going to talk today about Medicare Advantage, what's traditional Medicare, what's Medicare Advantage, how's it funded, some of the factors affecting your decision as to what type of plan you would prefer, and the status of Medicare Advantage in our market, and the impact on providers. So I will be speaking. Joel Beiswinger is our CEO. He will be speaking here today as well. And Dr. Ben Hess, we're expecting to come later on in the meeting. Okay, traditional Medicare. Traditional Medicare is a program that's available to individuals who are over 65, people with certain disabilities, and people with end-stage renal disease. It's a health insurance plan that's managed by the federal government. So when you look at this, what is Medicare? Traditionally, you've had Medicare Part A that covers your inpatient stay in the hospital. Medicare Part B covers your outpatient stay. If you're in the hospital for outpatient services, it would cover that. And it also covers your physician services in the clinic. Part C is what we call Medicare Advantage. And then you have Part D, which is your prescription drug coverage. What we're going to be talking about today is Medicare Advantage. So if you have traditional Medicare with a Medigap coverage, that's different from Medicare Advantage. So traditional Medicare, you might have Medicare A and B, and you have a Medigap coverage. Maybe you pay $200+ a month, and it covers your out-of-pocket after Medicare pays their portion. But Medicare Advantage is they cover both the Medicare portion and the Medigap portion. It's a Medicare replacement product, so it replaces that traditional Medicare, and that's what we're talking about today. So what is it exactly? It started back in the 1970s as something called Medicare Choice. And in 1997, it became official with the Balanced Budget Act, where it was called Medicare Part C. And in 2003, Medicare Part D prescription drug coverage started, and they renamed Medicare Choice to Medicare Advantage plans. So they incorporated all of that into one plan. And the plans are supposed to cover the same benefits that Medicare provides, but in addition, sometimes they offer additional services like vision and dental and some of those other things that traditional Medicare did not cover. And it's subject to insurance plan requirements. So if the insurance company required prior authorization for that service, you would have to get prior authorization, where traditional Medicare may not have required prior authorization. And Joel's going to talk about how is Medicare Advantage funded.
Thank you, Kim. Good afternoon, everybody. Joel Beiswinger, CEO here at Astera Health. So as part of how Medicare Advantage, or again, Medicare replacement policies, sometimes those change, of course, or terms are used interchangeably. Two primary funding means for how the insurance companies that are in this product market do this. So one, they get a fixed amount coming from Center for Medicare and Medicaid Services, or the federal government that manages Medicare. Instead of those Medicare paying directly to providers for your care, they turn that money over to the Medicare Advantage plan that you then work with for that coverage. Now I'm going to talk about this a little bit more from a historical perspective and what's happening these days here in a few minutes. The second means is whatever your premium is that you pay as you buy your plans. You have some premium based upon the product you buy, how many maybe extra benefits there are. Those sorts of things determine whether you have a $100 a month premium or $200 a month or $50 or whatever that amount is. Now, in terms of the fixed amount that comes from the federal government, there's a couple of nuances to this. And again, we have to remember this is insurance, no different than any other insurance. And insurance companies, the way they do their business is they take money in with an expectation that they'll pay less out. In the end, that's insurance companies make money. And most of the insurance companies that we're going to probably talk a little bit about today are, big corporations, for-profit businesses. So that fixed amount, I'm going to give you a little history lesson about Medicare Advantage and when it really started to proliferate around the country back in the early 2000s. Medicare takes a look at all the actuarial studies related to Medicare patients over a course of time and identify what's the payment amount that they'll make on behalf of you as a patient in whatever locale you live in. Historically, as this has been done, Medicare's looked at, what are you in an expensive state from a healthcare perspective or cheaper state? And, so Florida has historically been the highest spend state for healthcare, and especially Medicare, throughout the last 20 years. Other big states that you may think of similarly are the same, Florida, Arizona. Now again, lots and lots of seniors in those states for obvious reasons. And in some cases, maybe they're sicker people. So what they saw in Florida, they might pay on average $20,000 a year for a Medicare recipient in Florida and only $15,000 in Minnesota. Minnesota's typically ranked somewhere lower than half, maybe about 30 out of 50 states in how high Medicare spending is per patient. So when the Medicare Advantage products started to be sold back in the early 2000s, what my recollection and the research indicates is that the plans looked and said, well, we're going to try to market to younger, healthier seniors. We'll get that big payment from Medicare if you're in Florida, and then we can offer some extra benefits. Things like all of the prescription drugs, no deductibles or co-payments, maybe even no premium. We'll give you a health club membership. We'll pay for your transportation to visits, all those nice things. And even some of the patients, of course, in our areas get some of those things. That works out well. When you could sell that plan to a healthy young Medicare person, they took in more money than they had to pay out. That's the profit motive for insurance companies. Okay? Now, as what we're seeing, this a lot of Medicare Advantage around the country. They're getting into some of the patients who aren't as healthy. So we're seeing insurance companies realizing that some of the struggles financially here are pretty real. We've seen a lot of growth in this. Kim and I can recall back in the early 2000s when this kicked off, very little Medicare Advantage. We'd pick up a patient here or there for the first few years. Wasn't too big a deal. Now it represents over half. So this is national data, but our data is very representative and similar to this. More than half of our Medicare patients now have a Medicare Advantage plan. And we're going to touch on what that means from a provider perspective and what it means to your care. So when you're making a decision about whether or not traditional Medicare, maybe with a supplement or not, buying Part D, that track that Kim described, or Medicare Advantage is the right path for you, there's some things you have to consider. First of all, of course, is what are the costs? That's obviously probably the thing that we're all looking at first and foremost. What are my premiums going to cost me? How much out-of-pocket costs might I have if I need care? From a value equation, though, you have to look not only at the costs, but then what are the benefits? Do you get extra benefits? What type of care do they cover and do they not cover? And that's where there's really a lot of details to figure out. And between Kim and Dr. Hess, who's joined us now, they're going to talk a little bit about that later. You have to look at network coverage. And I'm going to talk about that a little bit more in a moment. Think about the type of care that you need. Again, if you're a real healthy person and you don't need much care, Medicare Advantage might be the best solution for you. But if you're somebody who's got, cancer situation going on, or you're going to need knee replacement or some of those sorts of things, you really have to stop and think about, how is that care going to be covered for me in the future? So it's not just, lowest cost isn't always best value. And always, 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 we would suggest is work with a local broker. If you watch any of the news channels, whichever your news channel of choice, CNN, MSNBC, Fox News, whatever, you see a ton of advertisements about Medicare Advantage products. Joe Namath selling forever who he sells for, I don't even know, I don't care. That is not the way to buy a Medicare Advantage, in our opinion. Because as soon as you have an issue, situation, if you don't have that local broker working with you, you don't have that advocate. So we've got one of our local brokers, Brittany from 218 Insurance here, just listening in because they're really in their blackout period with Medicare right now. But we will always advocate, talk to somebody locally about this. They'll help you identify what's the right plan and value for you. So again, some of those things I've talked about, what are those potential advantages for you? Again, it could be a lower cost option. Maybe there's some extras added in, like dental, vision, and so forth. Now, one of the things to really consider, I talked about network coverage. So in our area, we've always had some challenges here over the past several years. If you've had Humana as your insurance company, for about 4 or 5 years already, you haven't been able to go to CentraCare in St. Cloud because they made the choice back then that they would not accept Humana. And quite honestly, from a provider perspective, it's because we believe that our patients don't get the best care with what they approve or don't approve, and they're very hard on the providers from an administrative perspective and financial perspective. 2 years ago, Fairview University left our menu of places to send folks. Same reasons they backed out. Now, it's getting even worse. You look at this slide, the bottom left, a couple weeks ago, Sanford announced that they were no longer going to take Humana. The upper right, this is truly hot off the press. This news came out last Thursday. That is Essentia Health, so that's Duluth, Fargo, in terms of bigger hospitals. Brainerd, of course, for some of the stuff that we do goes to Brainerd, not accepting Humana. But it's not just Humana. You're seeing some of these places drop out of other plans like United Healthcare and some others. You look at our area, Humana is one of the biggest. My advice to you, if you have Humana, you're going to have to take a really hard look, talk to your broker about whether it's still the right plan for you or not. Because quite honestly, if you come here, we're still taking it, we will. But if you need next level care, the options of where to send you are pretty limited these days. Really kind of look around the tertiary world. There's a few places in Minneapolis, like Alina, which would be Abbott Northwestern or North Memorial, maybe Hennepin or Mayo. But the places that we normally get people to, generally Fargo and St. Cloud, are no longer options. And admittedly, this is not the end of this. These larger providers backing out. This is just the beginning, in my opinion. So with that, I'm going to turn it back to Kim and invite Dr. Hess up to help understand what are some of the impacts on our providers as it relates to your care. So Ben, for your benefit, we're recording, so if you guys are going back and forth, speak from the podium and use the mic, please.
Okay. A lot of what we see that creates additional burden for organizations is the additional prior authorization and the prior authorization process, where if you're on traditional Medicare, you don't have to go through the prior authorization process, but Medicare Advantage plans may require that, and most of them do. There's also, we see increased number of claims denials. Many of the denials can be overturned, but it's the process that you have to go through to get those denials overturned. It's going to require physician input, it's going to require our financial team's input, and an entire process to do. And also reimbursement challenges. We are expecting that our Medicare Advantage payers should be paying us what Medicare would have paid us, and we've had challenges with that and working with them on that. Some of the patient care impacts, I have a couple of examples that I'll read, but I'll ask Dr. Hess to speak about impacts to patients and delayed care and some of those things that affect their world.
Hello. Sure. I think one of the first things that I noticed a couple of years ago was that stress tests were getting delayed quite a bit. There was quite a process just to get people approved for that. And normally when we're ordering stress tests, they're set up as a fairly urgent thing. It's kind of a priority to get people in to get their heart checked out and to make sure they're not having a potential heart attack looming in the near future. So that was a significant concern, and definitely way more hurdles put in front of that than there used to be. We've also had issues now getting people transferred. That's going to get even harder, as Joel already illustrated. But I I think if you had Humana insurance, I really don't know where I would send you right now in the state easily. So that'll definitely be a concern moving forward. We've had challenges getting people to post-hospital care, whether it's home care services or skilled nursing facilities, if they need a little longer rehab stay. Those have all come up as potential delayed care or prolonged stays in the hospital that were really not necessary or justified. So those are just a few of the things I can think of off the top of my head. The substitution care, that's another challenge that we'll see. We'll order a test and they'll say, no, you can't do that test unless you do this first. Sometimes that's fine, sometimes that's a reasonable option, sometimes it's inappropriate or it delays things even further. So I think it's really taking the decisions out of the hands of the doctors at times. And, usually there's a reason I'm ordering the test because I know the patient, I know the situation. And now that decision-making is taken away from us, the people closest to the care.
Yeah, I have a few examples here, some real-life examples that I wanted to share. So this is a situation that has happened numerous times with a cancer patient. We've had cancer patients, and when you have chemotherapy, it will wipe out your immune system. So you correct me if I say anything incorrectly here, Dr. Hess. It wipes out your immune system, and one of the standards of care for some of these chemotherapy patients is to put them on Neupogen after they have their chemotherapy injection. And Neupogen will help stimulate the bone marrow to produce white cells so you can fight off any bacteria or any infections that you get. And in this instance, because Neupogen is a very expensive medication, but it's the standard on many of these chemotherapy treatments, the Medicare Advantage plan denied the injection. The patient ends up in our ER with a fever, ends up being admitted and hospitalized. Was that patient served well? Did she receive the appropriate level of care that she deserved for the care that she got? That's an example. We've also have a couple of examples with hip fractures or pelvic fractures. We had a gentleman with a hip fracture who was needed to be placed in a nursing home for temporary placement for rehab following his fracture so that he'd be able to walk around, and that care was denied. We had another patient that had a pelvic fracture. The pelvis was fractured in multiple locations due to some type of accident, and the care was denied for admission. They would only allow us to treat her as an outpatient. I have a letter I want to read just to give you an example. This is a stroke patient that we were trying to get placed in a nursing home. And this letter states, medical records show you were admitted to the hospital. You were treated for a stroke. You were also treated for a wound. Per your therapy records, you cannot walk. You can move in bed with the total help by 2 people. You have not had a change in function that needs daily skilled therapy services. No daily skilled nursing needs are noted. Your needs may be met at a lower level of care. Your needs may be met at home with around-the-clock supervision and home health services. Your needs can also be met in a long-term care facility with part-time skilled nursing services. Home health and part-time skilled nursing services would need to be approved by your health plan. This is coming from the health plan. Based on Medicare rules and your personal care needs, we are denying coverage for your admission or transfer to a skilled nursing facility. Those are the types of things that patients are experiencing with the Medicare Advantage plans. So when you're enrolling, we want you to be aware, if you're healthy, active, don't have medical issues, Medicare Advantage plans might be the right thing for you. But if you develop a more complicated situation, go into it eyes wide open, because this is a lot of what we're seeing, is a lot of these get denied.
I could say a couple more things about that case. So they were denying it because they said you could go home and have round-the-clock supervision and home health care services. That service is not available here. You're paying for that privately. So a lot of the things that they're recommending in this denial letter don't even exist in our area. So keep that in mind. This is basically a form letter that they are supplying to everybody, and they don't understand even the resources available locally to the patients that they're serving.
Yeah. So when you're going into it, consider your options carefully. Talk to a local broker. Because when it gets into where we're trying to appeal or overturn these decisions, I can beg and plead, but I really have no negotiating power with the payers. Your local brokers may not have much negotiating power, but they have the ability to say, hey, if you want me to keep selling your product, you got to serve our patients. So I would encourage you to at least, if you're considering a Medicare Advantage option, choose a local broker because they can help you advocate once you get into these denial situations. And there's a lot of questions. It's really confusing, and they can answer a lot of your questions as well.